Well, the show continues. We have another wonderful speaker lined up. In this case, it's Dr. CATHRYN TONNE. She's an associate professor at the Barcelona Institute for Global Health. Her research has investigated exposure patterns and health effects of air pollution in high as well as low and middle income countries and the health co-benefits of climate change mitigation via air pollution. She leads the working group focused on mitigation action and health co-benefits for the Lancet Countdown for Health and Climate Change in Europe. And she's also a member of the WHO Technical Advisory Group on Air Pollution and Health. She leads the ERC-funded Cardiovascular Health Effects and Air Pollution in Telangana, India, and is coordinator of Catalyze, a large horizon project focusing on climate change and health. Most of all, she's a wonderful colleague, and I'm glad to see her here and listen to her talk. CATHRYN, the floor is yours.
Thank you for that introduction, Mark. How do I get my slides up? There we go. Thank you. So, and I would also like to thank the conference organizers for the invitation to be here with you this morning. And I was asked to say something about urban environments and health in a more global context, going beyond the European context or high-income country context. So in this presentation, I would like to examine three specific questions related to urban environments. Firstly, what do we understand to be urban? Are urban environments actually bad for health? And why are urban environments central to reducing the health impacts of climate change? So I'm sure you've all seen data such as these from the UN World Urbanization Prospects. These data tell us that today more than 50% of the global population live in urban areas. In high-income countries, that's as high as 80%. As useful as these data are, they mask a tremendous amount of heterogeneity in terms of what is urban. These data are based on different countries' definition of urban, which can vary widely from a few hundred people in a settlement to tens of thousands. So we have a real challenge, which is that at the moment we have no consensus of what is urban. And that's not just a problem in terms of urban areas, but also how we think about cities and how we define how cities are embedded in space. I think that's illustrated quite clearly in this figure of Kolkata, India. The official boundary of the city, so the administrative boundary of the city, you can see in the purple dashed line. That official boundary corresponded quite well with the extent of urban area, so what was actually on the ground in 1975, which is that yellow color that you see. But as the years have gone on and the city has expanded out to 2015, where you see that darker brown color, clearly the correspondence between the extent of the city and the official boundary is quite poor. So we really need other definitions of the extent of cities than just having to rely on the administrative boundaries. One alternative definition, which you see here, is that black polygon, which is a morphologically defined extent of the urban area that can be used to define where the city is in space. The good news is that increasingly with remote sensing products, we have data streams that I think can really help us address this issue of consistent definitions of urban areas across space. This is one example from the Global Urban Footprint. So this is a globally available data set that provides an urban-rural indicator. You can see what that looks like here for Germany, but it's available in a consistent way at a global scale. But of course, for many of our health applications, we want to go beyond an urban-rural dichotomy. We want more of a sort of finer gradient in urbanicity or other definitions that capture better the functional dependencies between urban areas and their surrounding rural areas. This is another example of a gridded global data set that tries to do that. So what they've done is to basically map urban areas and the dependent rural areas that are linked in a functional way to those urban areas to really capture the goods and services that really tie these areas together. And they've done that for large cities, which are shown in black, intermediate cities up to a million inhabitants, which you see in blue, and small cities up to 250,000 individuals. So you see the urban areas and then this sort of linked, functionally linked rural areas that are connected to those urban areas. So remote sensing is really helping address this issue of consistent definitions across space, but also across time. To really examine the influence of global environmental change processes like urbanization on health, we need long time series, on the scale of a decade or more. So this is an example of an analysis from our group that used remote sensing data over about a 15-year period in combination with the random forest classification model to try and identify trajectories of land use change in a cohort outside of the city of Hyderabad in India. So this was a peri-urban area that was experiencing quite rapid urbanization. And when I say rapid urbanization, it's really happening on the scale of decades. What we did was to identify how quickly land use was transitioning from a natural land use to a built-up land use in a 300-meter buffer around each cohort participant's home. And you can see these three trajectories that came out of that modeling. So we've identified one group where really there was no change over time, another group that had a relatively slow transition from natural to built-up area, and another group that was had quite rapid land use change around their home. On the other side, you see the map. This is basically showing the 30 or so villages where the cohort participants lived. And below that, what you see there is that the most rapid transition group was most often in villages that were near to major roads, particularly near to the outer ring road of the city of Hyderabad. So we linked those trajectories to a number of cardiometabolic risk factors. We found overall that being in the fast trajectory relative to the stable trajectory was positively associated with all of the cardiometabolic risk factors. And there were statistically significant associations for systolic and diastolic blood pressure and waist circumference. So what underlies those relationships? Well, clearly it's many things. What we did investigate in mediation analysis was the potential contribution of physical activity and ambient air pollution. And we found a small but detectable indirect effect of both physical activity and ambient air pollution in contributing to those observed associations. So the first message I'd like you to take away from this presentation is really that improved exposure science is essential to understanding how urban environments and urbanization affect health. So the second question, are urban environments bad for health? This is, in my mind, a very classic editorial on the topic. This was published by Dave Leone in the IJE in 2008, and many of the insights in this editorial remain really relevant today. And in this editorial, he reflects on the largely negative view in epidemiology of urban living and urbanization on population health. And this is really in contrast to the much more positive view that is in other fields like demography and economics. he also advocates for epidemiologists to really develop a much more deeper, nuanced understanding of the influence of urbanization on health and really what underlies observed urban-rural differences in health. So why in epidemiology, and I would say in environmental epidemiology, do we have this somewhat peculiar and persistent view of urban environments being somehow bad for health? One possible explanation has to do with the specific health conditions at the time of the founding of the field in the mid-19th century. So this figure shows estimates of life expectancy at birth in England and Wales overall is that top time series, and in cities with 100,000 inhabitants or more, those are those two time series lower down. There are two coming from different estimates. And the red line corresponds with what's widely accepted to be the birth of modern epidemiology and environmental epidemiology with John Snow's investigation of the London cholera outbreaks in 1854. And you see that the cholera outbreaks correspond to this period where there's, at least according to these data, this very clear urban penalty. So considerably lower life expectancy at birth in these rapidly urbanizing cities compared to the national average. And this has been attributed to the relatively poor living conditions due to that rapid industrialization, such as overcrowding and lack of sanitation. So perhaps it's this sort of early imprint at the founding of the field that has somehow stuck with us that explains this idea of urban environments being somehow bad. I would point out that by the beginning of the 20th century, you see these time series converging, and actually that urban penalty pattern doesn't really persist for that long. So what do urban-rural differences in health look like today? So that's something that we examined in a large systematic review and meta-analysis focused on hypertension prevalence in low and middle income countries. We focused on hypertension as it's one of the main drivers of morbidity and mortality globally. And we extracted data from about 300 surveys, and you can see in that top panel the results showing the urban-rural difference in hypertension prevalence over time. So in the 1990s, there was quite a clear higher hypertension prevalence in urban compared to rural areas in low and middle income countries overall. But as time has gone on, that's really decreased considerably and today is quite modest. So hypertension prevalence is going up everywhere in low and middle income countries. And if you look in that bottom panel, you can see the pattern is really explained by the much more rapid increase in hypertension prevalence in rural areas, such that they've caught up with and in some cases superseded the prevalence in urban areas. We also saw a nonlinear relationship with economic development, which is shown here based on the Human Development Index. So what we found is that in low-income countries, it was clear that the hypertension prevalence was higher in urban compared to rural areas, but with increasing economic development, that really starts to disappear and then was reversed in upper middle-income countries. So that systematic review was focused on low and middle income countries. We didn't have data from high income countries to sort of see how urban-rural differences in hypertension prevalence varied across the full scale of economic development. But looking at other data, this is from the PURE study, they see a very similar pattern to what we found in low and middle income countries, and I've highlighted here their estimates based on high income countries. You can see it's a much higher prevalence in rural compared to urban areas. So these broad patterns are not just observed for hypertension, but have been observed for other health outcomes. This is an example of data for body mass index that comes from the NCD risk factor collaboration. These data are for women, and what you see here are the trends in urban and rural body mass index by world regions. So similar to what we saw in the systematic review focused on hypertension, in world regions with more low-income countries, you do see higher body mass index in urban compared to rural areas, but that over time that's disappearing in many world regions. And if you look very carefully at the high-income Asia Pacific and Central and Eastern European data, you can see that now it's rural areas that have the higher BMI. So another possible explanation for why we have this notion in environmental epidemiology of urban environments being somehow bad for health might be due to our emphasis on etiologic research. Many of you are involved in research documenting the adverse health consequences of environmental exposures concentrated in urban environments, such as ambient air pollution, noise pollution, light pollution, lack of green space. But if we look at that descriptive epidemiology, like I've just shown for hypertension and for BMI, clearly in many world regions, particularly in high-income countries, we see that there's not that urban penalty, there's the urban advantage. Actually, the frequency of disease and risk factors is lower in urban compared to rural areas in these settings. So how do we start to really understand what's driving the observed patterns in the descriptive epidemiology? What really underlies these urban-rural differences in disease? It's clearly not just one factor, it's not one environmental exposure, it's not just air pollution or green space, but I would argue is really the totality of environmental exposures experienced over the lifespan lived in an urban environment, or in other words, the urban exposome. So I think there's a very nice opportunity for us to use this sort of exposome approach to really try and understand in a much more detailed way what underpins these urban-rural differences that we see in the descriptive epidemiology. And so this, I think, is a nice way to really try and respond to that challenge that was put forward by Dave Leon in that commentary. And I think if we do this, we also see that we might be missing some very important things in much of our urban exposome research that we know are drivers of these urban-rural differences. So specifically, we know that access to services, particularly health services, access to better economic and educational opportunities in urban areas is a really important contribution to better health. So I would like to see that better represented in our exposome-based research. We put a lot of energy and effort into characterizing in detail environmental exposures, but don't necessarily have these other very strong determinants of health well represented. So the second message I'd like you to take away is that obviously urban environments are not necessarily bad for health. It's very context dependent. You've seen in the data that I showed on hypertension and BMI, it depends on time, it depends on world region, and depends strongly on level of economic development. So why are urban environments central to reducing the health impacts of climate change? The first part of that answer really comes down to just sheer numbers. This figure shows trends in the percentage population in urban areas by region and population size. Between 2018 and 2050, there'll be considerable growth in the urban population, and it will happen in largely populated world regions. So we're expected to add 2.5 billion people to urban areas by 2050, and 90% of that growth will happen in Asia and Africa. So this future urban development will happen in world regions that have had historically much lower per capita emissions of greenhouse gases. This is a figure showing the share of cumulative emissions from 1990 to 2015 and the use of the global carbon budget that's consistent with a 1.5 degree warming. So on the right-hand side, you see the share of that global carbon budget that would keep us within 1.5 degrees warming. We've already used 60% of that budget, at least by 2015, so it's more than that now. And the poorest 50% of the globe has used only 4% of that budget, whereas the 10% of the wealthiest population in the globe has used 31%. So there are really important equity considerations about how that remaining budget will be used to accommodate this future urban development. So this figure tries to put some numbers around what that might mean for climate change emissions. You know, the infrastructure for this future urban development has yet to be built. How that is built will have quite important implications for greenhouse gas emissions. So according to these estimates, building infrastructure for fast-growing cities in developed countries could release 226 gigatons of carbon dioxide by 2050, and that's more than 4 times the amount of that has been used so far to build the existing infrastructure in urban areas of the developed world. So clearly there's an incredible imperative to identify low-carbon pathways for urban development and, of course, to optimize those pathways to promote health. So we will have this large number of people added to urban environments, and part of that will also lead to a sort of concomitant growth in vulnerability and exposure to climate change-induced hazards. Looking back where most of the growth in vulnerability and exposure has happened so far, it has been in cities and settlements with low adaptive capacity, or really particularly informal settlements in low and middle income countries. Today, we have 1 billion people estimated living in informal settlements, or about 1/4 of the total urban population. So this is a really important population because of the size, because of the vulnerability, to understand how climate change will influence the health of residents in informal settlements. But there are a number of data and evidence gaps related to how climate change will influence health in these populations. These are 2 recent reviews that have looked at this population in particular, and I think what comes out is that there are still many gaps that remain. What we do know is that the exposure and vulnerability of these populations are shaped by a combination of individual factors, largely material deprivation, but also outdoor occupations and existing health conditions, and very much by socioeconomic and political factors, so lack of housing rights, political and social exclusion, and government neglect. These populations are particularly vulnerable to extreme weather events such as flooding. The epidemiology so far has linked extreme weather events in these populations to health outcomes such as food and waterborne disease, worse mental health, increased domestic violence, and poorer sanitation and hygiene, as well as health outcomes that are mediated by food insecurity and loss of livelihoods. So in thinking about this future urban development, realistically, most of the decisions will be driven by development priorities rather than climate change or health per se. But I think this is, there's an obvious need to consider these things simultaneously. And I think this is a very sort of intuitive and powerful key principle for action from this UN Habitat report, which suggests that we address development deficits with climate change adaptation and mitigation, and I would add health in mind, and address climate change adaptation and mitigation with development needs and health in mind. So clearly there's a lot of overlap between these areas, and that overlap includes areas of synergy, but also importantly, trade-offs that we want to identify in research in order to avoid in policy and implementation. This is a figure from the IPCC AR6 report on cities and urban settlements. I don't expect you to be able to see the details of this figure, but what it is showing is really a systematic mapping of a solutions framework to really identify this climate resilient development. So what is on the right-hand side are adaptation measures for urban environments and how they interact with these other dimensions. So I've highlighted health, mitigation, and poverty reduction. You see a lot of green in those red boxes. Those are areas of positive synergy between climate change adaptation and these other dimensions. But it's not all green. You also see this more rose pink color, which is highlighting where there are potential negative trade-offs in these of climate change adaptation and these other dimensions. What this exercise also shows is that there are a number of areas where we still have quite limited evidence. So there's a real need for sort of joined up research looking at this overlap between climate change action, health, and development to populate this sort of systematic mapping exercises. So I wanted to share with you one example from our group that looked at the synergies and trade-offs between climate change mitigation, ambient air quality control, and clean cooking access in the context of child stunting in India. So this was a scenario modeling study. We had 4 policy scenarios, which we compared to a business as usual reference. On the y-axis is the cumulative preventable number of stunted children relative to the business as usual. So the first policy scenario is a climate change mitigation scenario. So this involves emission reductions consistent with a 2-degree warming target. As we heard yesterday and in the climate change and health keynote session on health co-benefits, climate change mitigation has the opportunity to reduce ambient air pollution. You see that the contribution of reduced ambient air pollution to child stunting avoided in that green shading there. However, under the mitigation scenario in this modeling, it was estimated that the price of LPG, or clean cooking fuel, would be significantly higher, creating affordability barriers to clean cooking fuel and more people sliding back into using biomass cooking fuel. And that benefit that we saw from the reduction in ambient air pollution was completely overwhelmed by the increase in child stunting due to higher levels of household air pollution. So you see the net impact as that dashed line, which is below 0, so that's indicating an increase in the number of stunted children. In the next policy scenario, we looked at a combination of climate change mitigation with targeted policies to reduce that affordability barrier to LPG. And you can see that there's a much larger positive impact on prevented childhood stunting. We also looked at the combination of climate change mitigation with this clean cooking policy with more aggressive air quality control. So this included end of pipe emission control efforts. And what we found in that last panel there is really a synergistic effect with this combined policies. So we see a bigger impact, so 12 million stunted children avoided by 2050, and this was bigger than the sum of the individual policies that, themselves. So this very nice synergistic effect in that combined policy scenario. And that combined policy scenario was estimated to benefit the population subgroups that were most disadvantaged. So this shows projected trends in child stunting prevalence by population subgroup, and under that combined policy scenario. So you can see in 2050 a much larger reduction in the prevalence of childhood stunting in the poorer compared to the richer group. And similarly, we see much larger reductions in the prevalence of childhood stunting in the group with no education compared to the high education group. So a very potentially very positive impact on reducing health inequalities in India. So the third takeaway message really is that population and urban growth will dramatically increase the number of people most vulnerable to the health impacts of climate change. And finally, in conclusion, I really would like to stress the need for this kind of joined up research to identify the synergies and, very importantly, the potential trade-offs between health, climate change action, and urban development. And environmental epidemiology and exposure science have a very important role to play in delivering that evidence. It was very, very nice to see the session dedicated to Paul yesterday, the climate change and health session. And it's very hard to talk about urban development and climate change and health without feeling the real profound loss from his passing last week for many of us individually, but really for the field of environmental epidemiology as a whole. And he's already very dearly missed. And I will leave it there to say thank you, and really to thank my group who did the heavy lifting on these analyses that I've just showed with you, in particular Ottavio Ranzani and Carlos Milà and Asya Dimitrova. Thank you.
Thanks so much, CATHRYN, for this wonderful presentation and in giving us an insight in the issues of urbanization and health. We have time for some questions. Any questions? I see a hand going up there in the middle. Can we have a microphone, please? I'm sorry, I can't see who you are, but...
no, that's okay. I'm Wig Zamor from Somerville, Mass. Thank you for a very nice talk, and I want to thank IS Global for your continuous leadership in thinking about urban form and health. I have a question that I don't presume you should have the answer to, but as you were talking, especially in the beginning of rural versus urban, I thought back to Judy Laser's work at MIT, and one of the things she looked at was the footprint of New York City and concluded that its footprint was actually 8 times the scale of what happened within New York City. And that made me think about your contrast of rural and urban neighborhoods. And I guess the question is, how much have you thought about supply chain and the degree to which urban areas have some responsibility for the impacts on their full local and global supply chains?
So yeah, I think it's a really interesting point, and I think particularly in the urban sustainability and urban transitions sort of fields, which I would say would be really nice to see more integration of those fields with health and epidemiology. They have done some really nice work, really trying to look at these the sort of footprint issues. It's hard to, I think that there are some really interesting ways where that information can be included into basically studies looking at health, particularly in this sort of more global environmental change types of questions. But I think the definitions that we have been working with in the past so far are absolutely inadequate, and we need to be looking at these other ways of characterizing cities. It's not just in space. It can be through supply chains. It can be through some of these other more, let's say, functional networks.
Yes, there, please. Oh, Audrey. I'm sorry, Audrey, I didn't see you.
Yes, Audrey as an Imperial College. Thank you, Catherine. That was such a fantastic talk. I really, really loved it. And so you touched upon what we can do both as researchers, but also in terms of specific developmental patterns. And it seems to me completely overwhelming what needs to happen with informal sediments. Could you just expand a little bit on what you think needs to happen in terms of urban development, how to make those urban development healthier in the Minot, and what we can do about it ourselves? Thanks.
Yes, so actually, I think there's a lot of really great work that's been done. So, for example, that UN Habitat report has very specific recommendations of how to basically address in a very pro-poor way, reducing vulnerability to climate change and promoting development, and really looking at it in a way where adaptation does not necessarily have to mean high emissions approach. So where do we find these triple win type of solutions? And so there are some really great guides already out there of what we should be looking at. So I would say that the real research need is then on the basically interventions and evaluating these approaches.
At the back, Sotiris.
Hi, CATHRYN. Fantastic presentation. Thank you very much. I want to ask you about the synergies between urban air quality, climate change mitigation, and urban heat islands, and whether we should be looking more at the synergies between these two areas of work and win-win situations, win-win solutions, which will improve air quality, improve climate change mitigation, and also reduce the overheating in urban areas.
Absolutely, and I think the session yesterday, there were some really great examples showing basically epidemiological studies looking at how, basically these synergistic issues. So how does urban heat island influence the impact of temperature and the interaction between temperature and air pollution? So I think this is a really important area of research, and we saw some really great examples yesterday, and I would advocate for seeing more of that.
Any further questions? Here at the front. Sorry, you're behind my screen.
Thank you very much. I think, this is a very important topic, the rapid urbanization in the world. And I would like to ask you, how to define urban and rural, and what are we trying to differentiate? Like, is there misclassifications? For example, so some cities, people living in the rural area, a lot of people, but most of their work and education are in the center of the city, in urban area. And another example is like in China, many people living in the rural area, but when they get sick, they access healthcare in the urban area. So how, this kind of people, they live in rural area and access healthcare in urban area, we find they are particularly vulnerable. So how do you consider this kind of population, and how do you differentiate urban and rural in terms of this kind of issue? Yeah, thank you.
It's a very important question, and I think the way you would define, let's say, not urban and rural, or whatever definition you want to come up with, whether it's something that's looking at a gradient or something that's looking at these functional dependencies, it really depends on the research question, the health research question. And I think there are a number of, let's say, options out there, but it really, for example, if you want to look at something related to urban heat island, using something that's very much based on the physical reality of the built form makes much more sense than trying to use administrative boundaries, for example. So we had a very interesting workshop a few years ago. Mark was there with a number of these, let's say, urban systems people and people who've been working on urbanization and health for many years, remote sensing people. And we have a paper that has some recommendations of sort of which ways you might want to try and approach characterizing urban environments related to the health questions. So I can refer you to that. So, thank you very much.
Thank you very much for your answers.